Good evening, people. Hope everyone's doing well. Everyone's had their haircuts. Let's see if we can get Imi involved. Talk about single central implants today, management of that. Hopefully you've seen Imi's work. He's a master of that. And what we'll be doing throughout the whole thing is if you've got any questions, pop them in the Q&A or in the comments and I'll get them to him. If not, we'll do it all at the end there as well. Imi's on, just waiting for him to join in. Hi, Salim. Come on, Imi. Hey, Gary. What's going on? Got the Cardiff Dental techs on too. I think Imi might be having some trouble getting on. But if you've got any questions, then just get writing in comments and things already. And we'll have them saved up for Imi when he does get on. But yeah, we're going to look at it, mainly try and do it from a, I'll try and add you again, but here we go. But yeah, we're going to look at it mainly from a GDP's perspective as well, referring in what kind of things you want to do. What kind of things would a referring implantologist want to say? Hey, Matt, if Imi can't get on, I have to talk to you. Bring Matt on to talk about this instead. But hey, that's fine. Let's work this out. Dr. Shannon, how you doing? We got Richard Lee as well. Richard, have we decided what we're talking about in a couple of weeks as well? Celine, we're talking about single centrals. Imi, I've tried to add you again. Try again, bud. Hey.
Well, that wasn't a good start, was it?
Very smooth, very smooth. I like it.
I like to make a big entrance.
Yeah, dramatic.
Yeah.
Have you spilt something on the back wall there?
Yes. Well, this is part of my lab prescription technique.
Here we go. We're cutting to the end now, there.
Yeah. Yeah. No, that's just something my kids put together in the playroom.
Oh, big fan. I like it.
Yeah.
How you doing, man? You okay?
Yeah, very good. How was your day?
Yeah, it was good. It sounded like yours was more stressful than mine, rushing back last minute.
Yeah, just about got back in time, which is good. Probably broke speed limits, but we got.
That's all that matters.
Yeah. Thanks for having me on. Really excited about this evening.
Yeah, I mean, we've been planning it for a couple of weeks now. I think we've got some really good stuff. So I'm really looking forward to it. I mean, for just anyone that's not sort of aware of your stuff, do you want to just give us a quick little intro about yourself? And obviously, we're talking about single central implants, maybe a little bit why that's sort of, I know it's not all you do, but it's what sort of a lot of people know you for. So just sort of run us through that.
Yeah, so I think a lot of our focus for Rupert and I this evening, we want to make it sort of GDP driven as much as possible, and that is the basis of what I do. So I'm a general practitioner. Feel very lucky that I get to sort of do surgery and get to restore all of my work as well. So I think implant dentistry for the GDP is very viable. And I've been on one of those journeys myself where I've started off doing really simple stuff over the last sort of probably 9-10 years, and as time has progressed, I've branched out a little bit further. So hopefully some of the stuff I can show this evening inspires other people to either start doing implants or helps them move on to the next level.
Oh, perfect. So what's your actual pathway then? Have you done MSCs, master, like what kind of dips or?
Yeah, so I did 2010 to 2014, I did a master's. That was at Bristol. And that was a really good starting point because, scientifically, it gave me a really good sort of basis for understanding all the right techniques. But I think now I probably do things quite differently to what we were taught on the MSc. I think, time evolves, but I think those principles of doing treatments that are sort of scientifically proven and critiquing yourself appropriately, I think that stands us in good stead. So MSc to begin with, and then thereafter, I've kind of learned you know, by trial and error, hopefully more sort of trial rather than I wouldn't say I've done a huge amount of courses. I've never really had a mentor in implants or anything like that, and I've kind of just, you know, I was always surgically competent and felt quite confident with oral surgery, having done oral surgery posts. I suppose that probably helped me. But it's one of those disciplines that, you know, I still enjoy restorative, I still enjoy composites, I still enjoy crown and bridge work, and it's, you know, for me, if I think back to my day today, it's like a wonderful mix where I've done, what did I do? I did an extraction, I did 2 grafts. Following lunch, I did a review of the free gingival graft, then I cemented onlay, then a composite, and then did a new patient consult. So for me, it's like, it's the perfect mix of what I want my days to be like. You know, so, and implant wise, you can do it. So, which is great.
Perfect. So I think you've got some cases you want to show us. Do you want to do those throughout, or are we thinking we're going to go through our 3 steps and do them at the end, or see where we end up?
Well, you can, why don't you, you know, you feel free to ask me some questions. Maybe in between I can tie into a case to maybe show things that might relate to it.
Perfect. So the sort of overview that we're looking to do, guys, we're going to sort of go through from assessment to the more surgical side, soft tissue management, and then the pros side and lab communications and things. So, and as Zimi said, we want to really aim this at GDPs, or not completed GDPs, but sort of look at it from the perspective of GDP. You know, if you, where I work with prosthodontist as well, and I did a lot of shadowing with him, and the little things that you pick up on, you know, risk assessment, aesthetic risk assessment for these kind of things, completely changed how I would then talk to a patient. Before I'd be like, yeah, you need an implant, go and see the implant. Suddenly you're looking at smile line, you're looking at, you know, buccal defects and things like that. So if you've got a new patient in your chair, referred to you maybe for an implant, what sort of things do you wish the GDP had maybe mentioned to them if it's going to be a particularly challenging case, or what things are you looking at to think this might be a aesthetically quite a challenging case?
Yeah, so I think you know, the most important part of that is often with you know, it might come down to the confidence the GDP has in discussing it with the patient. But I think the first thing I want to glean is a bit of a history why the tooth was lost. So I think within the history, I will find out so much information as to what's going on. So say, for example, the tooth, what is important is when was the tooth extracted? So if the tooth is present and it's there, of course, we can assess everything. But if the tooth was extracted 8 weeks ago, then we know that there hasn't been too much remodeling. Maybe the bone is okay. But if it's been extracted, hey, Curry, top 3 in the world, that is, yeah.
It's a big shout.
Yeah, I don't know what to say. So I think when the tooth was extracted, but also what would be really useful to know is how did the extraction go? So was it straightforward? Was the root fractured? You know, what was the buccal plate like? All of this stuff. Yes, we can take a CT scan. Yes, we can find it out. But you know, you're already starting to get a sense of the case. When we're talking about anterior implants in the maxilla, you know, the bone there is so thin. So we know with more often than not in a healed site, it's going to need GBR. So I think when you're referring a patient for anterior implant, whether it's something like a missing lateral, you know, that tooth hasn't been there, the bone is going to be so thin. That case is missing laterals is going to be one of the hardest cases. So, you know, as a GDP, you should, you know, you might already need to be aware that it's going to need bone grafting. It might need soft tissue grafting. You know, certainly where I come from, if I'm working in a healed site in the aesthetic zone, more often than not, it will have a graft simultaneously. If it needs it, you know, if it needs staging, that's fine. And if I graft in the anterior zone, it will always have a soft tissue graft at the same time. So, you know, most of my principles will be based upon overbuilding the soft tissue, and then I work back from that. Because if we haven't got enough soft tissue, the aesthetics are going to be, you know, they're going to be suboptimal.
Yeah, absolutely. So I think that's something maybe I was going to ask you sort of later on in soft tissues and the surgical side of, you know, is there sort of the stages, and is there a particular way that you always stage things? So we'll get to that towards that middle stage. So in terms of risk assessment, so you do the ITI has like a, you know, easy, like simple, complex, advanced things like that? Are you looking at it from that kind of thing? Because I know you had some stuff with the ITI before, didn't you?
Yeah, so yeah, I've done that. I mean, how my performer normally works, like the first thing I'm looking at is, um, patient expectations.
Hmm.
That's obviously really key. Then we're looking at smile lines. Um, more often than not, unfortunately, I only tend to get referred to cases where they've got really, really high smile lines. I'll show you guys the case I'm doing tomorrow morning, and that is, as high a risk case as it comes. Smile line, patient expectations, and also really useful to know in the referral how anxious the patient is. I think that's really important. Then the most important thing coming to is really that soft tissue. So how much keratinized tissue do we have? Do we have 1 millimeter height? Do we have 2 millimeter height? That sort of thing long term for an implant isn't going to give us stability. So we want to know about how much we've got, and then we want to know how thick it is.
Hmm.
So, if you stick your probe into the sulcus and you can see your probe, then you know that biotype is pretty thin.
Hmm.
That biotype is pretty thin. So around an implant, I'm definitely always going to thicken that. I think that's really crucial. So we want medium, we want thick biotype patients. So that's a huge part of the risk factor. So when you're seeing patients in the chair and you see minimal keratinized tissue, you see very thin tissue, then I think it's a really good thing to warn patients that actually, yes, for long-term predictability, we're going to need to graft this as well.
Hmm.
I think that's really important. And then the other thing to be looking at, say I'd mentioned a missing lateral, so really important to be considering the mesiodistal space. So is there enough space to place an implant? Because sometimes we might be referred a case for a lower incisor, and there is just not enough space. There is just not enough space. So as a golden rule, you might get away with 1 mil, but you want at least 1.5 mil to the adjacent teeth.
Hmm.
That's really crucial. So if you're placing a 4 millimeter implant, you want a 7 millimeter mesiodistal space.
Which is
If
where you
not,
always struggle with lower incisors.
and, I mean, lower incisors, you can get away with it. You can use a 2.9 millimeter implant, 1 mil either side. So if you've got 5.5, and you're adept at placing it, you'll probably be okay. You'll probably
Yeah.
be okay. But mesiodistal space is important. Intraocclusal space. So again,
Hmm.
assessing that, are they going to need orthodontics to increase the clearance? Do we need more space? At least intraocclusal clearance, we want 7 millimeters. That's pretty important. And then the other thing I'm really interested on the PA. What are the interproximal bone peaks like? Because if we've got good bone peaks, if we've got good papilla, then we know that our aesthetic outcomes, we're more likely to get a good result. If those bone peaks are pretty flat on the PA, then actually you can start talking to your patients. Well, look, you might end up with a bit of a black triangle. Do we need to do some bonding on the adjacent tooth? And you're tying in things like that at the outset.
Because it's that, I mean, this is something that's come up quite a few times over these talks, is it's realizing these things before it could potentially happen, because then it's consent and not an excuse on the day when suddenly you go, oh, we need to do bonding here, or oh, we're going to lose the papilla.
Yeah,
So yeah.
absolutely. And, other things that are important, it's obviously crucial what's happened to that tooth. So if that tooth had a buccal root fracture on a post crown, which is one of the most likeliest things, and the tooth is there, then I'm not going to really be doing an immediate on that.
Hmm.
And that's going to, if a tooth has had a buccal root fracture, we know that the buccal plate has gone down to the line of the root fracture. We know that's going to need GBR. For me, historically, I've always extracted the tooth, let it heal up, let the soft tissue heal, and then I'll place with GBR, at 6 weeks. In my hands, I don't go for immediates in those sorts of instances. So, by nature, I'm pretty cautious with my cases. If I think something needs 3 months to heal, I'll wait 4. If I think it needs 5, I'll wait 6. And I suppose the more competent I feel that I get, maybe sometimes I can push it a little bit further, but with a good understanding of where the limits are.
Hmm. So I think that's, you've made some really good sort of points on assessment and things like that. 'Cause I think it is important to know, even if you don't rattle off all these things before you refer a patient, just to say, oh, this could prove quite difficult, or you may need require. It's things like the GBR or tissue grafting and things like that. Toothy pals nuts the haircut. Things like that can go from it being a simple implant to needing a lot more surgical consideration. Obviously, that changes costs and things. And what you don't want is a patient going there, looking at your website, seeing an implant is X amount, and then they turn up and, you know, you've added a bunch on because they need other things. And
Yeah,
being able to spot things like that is important, I think.
yeah, absolutely. And you know, you never have to, if you're referring someone in, of course, whoever you refer to, it's good to get an accurate gauge of their fee structure, because, you know, naturally, if you send a patient for an implant and you say it's going to be £2,000, you know, the patient's going to be pretty miffed with both parties when they go for the quote and it's 5 grand, you know. So I think, you know, get in contact with your referrers, find out what their fee structure is, and you know, hopefully in the assessment of the case, you may be able to get a better gauge on what things might add up to. You know, again, we're talking about single centrals. You know, historically in the past, if a patient said to me, "Oh, look, I want to try and reduce some cost, and is there any way you can reduce down treatment? You know, take some shortcuts." And you know, 5-6 years ago, I may have said, "Oh, look, we'll go straight to permanent. It will be fine." Whereas now, you know, yes, if I'm doing a 4 or a 5, I'll go to permanent. But now, you know, I factor in everybody will get a provisional, anything, you know, in the anterior zone. And then you factor in that, you factor in a few appointments to change the emergence, to, you know, add composite, remove composite. So, you know, some of these single central cases can mount up pretty quickly. But of course, you know, if the patient has high expectations and wants the perfect result, then you've got to go that extra mile.
Perfect. So I think talking emergence and things like that sort of starts to lead us down into the soft tissue management side of things. So you've mentioned papilla as well. You've mentioned biotype. So what kind of things are you looking for, and then how are you actually utilizing those things, and how are you working with them in terms of surgical soft tissue management and things like that?
Yeah. Rupert, shall I turn around my screen and show
Go
you
for it.
laptop? Is that all right?
Yeah, go for it.
If I can manage that. There we go. So hopefully everyone can see that. So, you know, this is, you know, classic case referred to me. Going to be in the chair tomorrow morning. And, you know, this lady, again, the history is so important. So she's had full mouth rehab. She's got mono Emax everywhere. And, you know, one moment of talking about looking at the history with her, and you know that she's smashed every restoration she's had placed in her mouth. She doesn't get on with splints, so she hasn't been wearing them. And you know, so this case comes in. So number one, we've got all those risk factors, which is huge with implants, because we know in vertical forces they're great, but as soon as you put lateral forces on them, on a case like this, it's going to hate it. It's going to hate it. But, you know, this case, luckily the root is there, which is great. But if you look at the slope of the maxilla up there, you can already see the outline of all the roots. So we know, even without a scan, you know that she's got paper thin bone up there, but the buccal plate's going to be intact. So, you know, this sort of case is ideal. In the past, you know, 7 years ago, 6-7 years ago, I probably would have extracted the tooth. I would let things heal up for 6 weeks. I would have placed my implant with any GBR, and I would have CTG'd it as well. And, you know, you look at that, and with time, you think, well, is there anything I could have done quicker for the patient? Should we be actually trying to regenerate the tissue, or should we be trying to preserve it? So, you know, for me, this case is classic, where I don't want to do any vertical incisions around those crowns, because aesthetically it's going to compromise things. So, you know, the plan for tomorrow is that she will have that tooth extracted. We'll do an immediate placement, and to try and preserve that papilla, we'll actually build, I'm not going to immediately load it, but we will build a customized healing abutment. And, you know, depending on how I feel the tissue is, I might also do a CTG underneath there as well. And what that's going to do, you know, that by the end of the procedure, you wouldn't even know that we've been in there. So the papilla will hold. We won't need to regenerate anything. And, you know, aesthetically around those other restorations, you know, nothing will be affected. So, you know, that's the plan for that sort of case. But if I showed you a stepwise process of this case, so there's another single central. And this is something that I'm midway through. I haven't quite finished it. She's almost at the permanent stage, but I feel I can show you a little bit about emergence and a little bit about soft tissue here. So this one we extracted, and actually I let it heal. I didn't place an immediate implant. She didn't want to do anything about the lower teeth, because that, you know, of course we offered ortho. And this, you know, without showing you the surgical pictures, and going through all of the surgery, you can see here that I've placed the implant, I've GBR'd it, I've done the soft tissue graft, and we've closed everything underneath that. And when you look at that, you can see how I've just got abundant tissue. So that's so much easier to work with. I want to be at least, you know, I want to be 2 to 3 millimeters incisal to the zenith on the other central. And if I've got my soft tissue bulk 2 to 3 millimeters incisal to the zenith on the other central, then we know the outcome's going to be good. We know the outcome's going to be good. So here's her site, looking from on top. And when you actually look at that, if I'm critiquing myself, yes, we've got lovely tissue, but if you actually look at the buccal profile there compared to the other central, the buccal profile is not as good. And actually the reason that is, yes, I've done GBR, but actually that's because I've done it as a healed site. I've done it at 6 weeks. But had I done an immediate placement, would it have still looked like that? I don't know. Probably it might well have done. But, you know, now you see guys that are doing partial extraction therapy, and that sort of, you know, where you retain the buccal fragment of the root and place your implant more palatally, well, the buccal profile you'll get on that will be completely different. You know, that's something that's been around for a few years, and I don't do any of that at the moment. But, you know, in this case, we've got the volume we need, and then we move to exposure. Okay, so we've exposed the implant. And of course, with an exposure, the aim is that you're not trying to disturb the tissues. You're trying to be as minimalistic as possible, but you're obviously trying to get to the implant. So exposure done. And there's my initial healing cap. Okay, so this is a peak healing cap, which I like to use. Blends into the tissues nicely. I like the fact that it's pink, so I'm fond of it. And then you move to the restorative phase. So at this stage, she's got enough tissue there. To be fair, when you work with a great clinician like Ben, he could probably, if I went to permanent, he could probably get the emergence as we want it. But, you know, we go to temporary. So impression taken, open tray impression technique. And then this is where we are. Okay, so we're in a good place. And then we move to the provisional. So this is the provisional, which, you know, we've gone back and forth on. You know, there's times where we've downplayed our provisionals because patients have run away with them. So I've got loads of patients who've never come back.
You've got to be careful.
So that's one thing. And then of course you're trying to ramp up expectations as you go, and you want to make sure there's room for improvement. But this one was pretty good. This one was pretty good. So there's her provisional, and about to be seated, and there it is. Okay, so this is a really good view of what came back from Ben. And you can see there that the, you know, it's a PMA temp, which he's customized with some composite. And you can see there our emergence angle. So the first thing that I will do is I will ask him, we'll make sure we don't press on the tissues at the first temporary crown that goes on. So it's almost like a little bit of a ridge lap, a tiny bit, but actually what it's doing, it's giving a chance for the tissue to really sneak in underneath here. Okay, so this is the analog. So here's our replica implant. Here is our TI base on the temporary, and the tissue's coming in. And then gradually, as that heals, you know, I'll leave that in place for 2 to 3 weeks, get the patient back, and then I'll customize it. Okay, so this one, I think I did it about a month later. I added the composite back in there, and then we reseated it. So that was when I took it off after I took the first one. So you can see you're starting to get a better profile. And, you know, that's after I've added a little bit. And you can see the blanching. You're only aiming for, you know, 5 minutes blanching, 2 to 5 minutes blanching, nothing more than that. Otherwise, you're pressing on it too much. But, you know, I'd rather spend 3 appointments getting that right rather than overcooking it and just killing the soft tissue. You know, so less is definitely more. And, you know, this is a nice one that combines what you were asking about surgery and soft tissue surgery. So again, another single central referred by a local practitioner. So when I look at this site, you can already see that there's a big defect here. Okay, there's a big defect. There's a big indentation there. Yes, the adjacent restorations aren't great. So with this case, what I did is I flipped the tooth. So, I often do that with a single central, try and show the patient what we need to achieve. So, just really simple on Keynote, flip it over, put it in the space, and then you get a good visualization of what we're trying to achieve. So you can see the site there. So pretty, pretty narrow site. That's a 4.1 millimeter implant, but you've got the buccal threads exposed. So for me in the anterior site, I will always chuck loads of bone in, overgraft it because you're bound to lose a little bit.
Yeah.
So there's my graft. Okay. Obviously a lot of my graft there, you want to make sure coronally, you've got a lot of thickness there. And I have lots of slides of this, how I tend to, secure the membrane, but I won't go through all of that this evening because we're tight for time. But this is the key part. So the key part that you want to warn to patients is when you do big grafting, naturally you have to advance the tissues a lot. And that's to get the tension-free closure. So you can see here how much distortion I've caused to the mucogingival junction. Where are we? Where's the cursor? There you go. So what should have been there, the mucogingival junction, is now down here. Okay. And, so we've got a significant decrease in keratinized tissue. But if we don't do that advancement, the flap's going to open up, the GBR is going to fail. So we need to do this first. You need to get it tension free. And then the patient heals. So here's our healed patient. You can see my GBR is looking good. You can see that there's no, the flap margins are good. I will always, I'm not somebody that does it without vertical incisions. I tend to put verticals in there. I find that that's really helpful, number one, for closure. And number two, I like to harvest from the patient as much as possible. So if I raise a big flap, it means that I can harvest locally. So, the aim for this now is how do we get more keratinized tissue here? So we took a free gingival graft. So we take a free gingival graft, we re-establish the vestibulum. So you just basically move it further up the lip into the sulcus, and then you attach your free gingival graft. And that's us there. Okay, so now we know for the long term, would that patient have been okay with that much keratinized tissue? Well, I think you never know, because actually they don't it's not integral to the long-term, the studies don't show a huge amount of difference, but we know that tissue is so much harder to clean. It's so much more uncomfortable. So we want to get back to the norm. Okay. So is that helpful with regards to soft tissue?
That's spot on. So what, grafting wise and stuff, what stuff do you tend to use? And
historically I'm 50% autogenous, generally speaking, and then dependent on the site, I will mainly use BIOS, but actually more and more now, say for example, ridge preservation, I'm tending to use allograft for, which is working out really, really well. Or say for example, I've got a case that I'm doing vertical grafting on for a posterior mandible, and there's impacted wisdom teeth, and there's a limit to how much autogenous I can take from them, that I might use 50% autogenous and then top it up with some allograft and then use some BIOS on top of that. So I'm conscious to use too much xenograft because I find that it never really turns into true bone.
Yeah, you end up with just sort of, it looks good on the day and then it disappears later on. We had a question actually about about soft tissue grafting. Actually, have you ever had situations where soft tissue graft doesn't take, and if so, have you worked out any sort of factors that sort of indicate that there's a chance that grafting isn't gonna take?
I think I think I'm, by the nature, like I said at the beginning, I'm really cautious. So I haven't had one fail. Maybe I haven't done enough. But I think the biggest thing that I'm very wary of is patients with obviously uncontrolled disease. So those that have uncontrolled diabetes, those that have uncontrolled periodontal disease, and those patients that are smokers. So if anybody's a smoker, they don't get any GBR from me. They don't get any soft tissue grafting. Patients that I know really well for long term, if they were a low smoker, I will place an implant in them in a straightforward site. if they're accepting of the risks. But beyond that, I won't move to any other complexity of surgery at all. And often I ask, I want at least 6 months proof that they've stopped smoking.
Yeah, fair enough. Dr. Viren's just asking, can you talk a little bit about what you use for temps or provisionals following XLA and implant placement? So I'm just saying immediate placement there. Are you doing temporary crowns? You said certain situations you're not. Are you doing, little flipper denture? What kind of things?
Yeah, so number one, the first bit of advice is that, especially now that masks are out, if with big GBRs, with big cases, their temporary is confiscated. So I confiscate it for 2 weeks because, certainly nothing should be mucosal borne when you've done implant surgery. So something like a flipper denture that will just press on the area will... is just a complete no-no. And even if a patient says they're not going to wear it, just take it from them because they are going to wear it. So that's the first thing. So essentially you want something tooth supported. And what I tend to do is actually all of my patients get 2 Essex retainers with the tooth in it. So they've always got a spare. I find that works well. Even when I do a placement and GBR and CTG, I confiscate that as well. And I tell the patient, you've got a mask at the moment, you've got a mask on. It's not essential. And if you want your case to work, I would recommend that you don't wear a provisional for a few days until the swelling goes down. So once the swelling goes down, they can come in, I can adjust it, and then I put it in.
Perfect. Lux Dental are asking, are you always going papilla saving with your incisions, or is it more case by case?
Who asked that, sorry?
Lux Dental.
Okay. No, I'm not actually. So the papillas are always included in my flaps. And I suppose, I'd say the longest part of my procedure is actually suturing up. So those that work with me normally have a timer as to how long it's going to take me to suture up.
And taking bets beforehand.
Yeah, and, very specific. So, when I started, all you're thinking about closing the flap. Now there is a strategic point as to which suture I do at what point. So I might pick the midpoint horizontal mattress to start with. Then I'll go to the top of my vertical relieving incision on one side. Then I'll go to the top on the other side. And it's all very strategic because what you find when I started, and you might start from the left and do a couple of sutures and work your way across, the flap will always pull, and then you'll end up having to open it up. So, the key thing is to look at all the finer details. Things like your bites. Is your bite on one side of the flap exactly the same as the bite on the other side? Is your incision going through a vessel? When you pull out the cheek, are you looking where those capillaries are running? Because yeah, you'll be fine if you slice through one, but actually for the healing, wouldn't it be nicer to just run adjacent to one so you're not affecting the blood flow, so you're going to get less scarring? So little things like that are really important, but my papillas are always in the flaps.
Fine, perfect. A little question there about altering your temps and things. So I sort of wanted to ask you on this as well. So what's your usual time frame in terms of, you're saying there you're altering emergence profiles and things like that. So do you have like a general timeline that you work to if it's a sort of placement, healing time, temps, altering emergence profiles, and then what's the sort of rough timeline usually?
Yeah, so if I've done, so say for example, that chap that I just showed, with the GBR, and then I've gone back in and done a free gingival graft. So usually I will look to expose the implant at 6 months, and then my temporary is delivered, and in that time they've obviously got their Essex. And with time, maybe I'll shorten that time frame, but I'm pretty methodical with that, with significant cases. And then the temp will go on. The first thing, it will sit there for 4 weeks. Then I'll get them back in, and then usually the changes are every fortnight. So every fortnight, and then when I get to my final position, which I'm happy with, I might leave them like that for 3 months. I'll leave them like that for 3 months. So often, some of my single central cases take a year. They're usually, I tell patients it's a 12-month program, and with that, at least it irons out any issues they may have, speech-wise, length-wise, shade-wise, all the rest of it, until we go to finals. So, I'm pretty slow through the process. I'm pretty slow through the process, which gives me plenty of chance to take photos, which is great. But
Yeah,
that's
lots of comments on the photos.
yeah. So you know that is that's my usual state of play. Actually, this is a really nice provisional I wanted to show you. So this is another single central. I haven't showed the surgical pictures of this one. So that was her provisional. That actually needed a lot of changes chair side before I fitted it. So there it is in situ. Unfortunately, she didn't want her upper left 2 crown change, so she was referred to me. So I pleaded with her to let her dentist take that. The other thing, she didn't want this area filled, and when we went to permanent, she didn't want this done either. So we had to go smooth. And here you go. You know, this is a really important stage. So you've worked so hard on your emergence, so it's so important. I know some people might be along the lines of that if you stick your impression coping in as quickly as possible and squirt some composite down there, it will get your true emergence. But you know, as soon as you take your crown out, that tissue rebounds instantaneously. So you have to take a replica of what your emergence is on your crown so that you can reproduce it. And you want to come to that one. And there's her final restoration, which is fine. The only bit, this is a little bit warm compared to here, but I think the issue is this is obviously bulkier. This is bulkier than what this is. But she was delighted in the end. But I think if you look at that for the incisal 2/3, it's absolutely spot on.
Well, I mean, this is leading into our next sort of section now, lab communication and stuff. So one thing I wanted to ask you there, looks like you're always doing impressions for your final. You're not doing any scans, anything like that?
No. So scans wise, I mean, you know, if you you know, Ben, my technician, is very, very adamant that if I took scans, he would want me to take impressions as well, because he doesn't feel the scan gives him the surface texture. And we know from like, say, Stuart's talk with you a couple of weeks ago, and you know, all of these aesthetic restorations, whether it's implant, whether it's composites, it's all about texture, it's all about shape. So you know, for us, I'm still all conventional. I don't do any scanning for anything, just simply because I'd have to double up. And you know, at the moment, he gives me such a accurate reproduction of everything. You know, I can't argue with man.
Yeah, absolutely. No, perfect. So, yeah, let's go straight into the lab communication, because this is the bit I'm most keen for, because you started to show your little doodles and things then. So yeah, I love these things that you do, and the detail that you're looking at is great. As you say, you get to have a look at it throughout all these stages. And the Mr. Essex dentist just wants to ask about money. Are you charging appropriately for your provisionals and factoring in? Someone also said you should make sure they're paying in full before those temporaries, because they might not come back. So yeah, are you factoring all this in, these additional appointments, or how are you working that kind of stuff?
Yeah, it's difficult because, you know, if I look at it, you know, probably the time I spend on a single central, you know, it would probably be, you know, it'd probably be more cost effective doing composite veneers for a morning, and doing tons of composite veneers. But you know, I feel my charge is a fair reflection, I feel, of the quality of the work. It's certainly, you know, I wouldn't say that I'm a cheap dentist. It's certainly, if I look at all the practices local to me, you know, most of them would probably do implants a little bit less than what I will be charging. So I think I feel comfortable with the fees that I charge, that it kind of meets halfway between the time that I spend and the quality that the patient is getting. Because of course you want to be conscious that you want to do the work, you don't want to price yourself out. But it's important that you value the work that you're doing, and I certainly feel I do. You know, I certainly feel that I do get a full value for the effort and time that I put into it.
Perfect. So yeah, lab communication things. You've said that you've maybe altered the temporaries a lot. So are you doing like an impression of the temporary if you're both happy with it, or a scan or photos of that? What are you sending to? It's Ben, isn't it?
Yeah.
So what's your guys' workflow and communication? Are you doing Dropbox transfers, or how does it look for you guys?
Yeah. So you know, if I get to my final implant appointment, the first thing I do as soon as the patient walks in the room is I'm doing my shade assessment. So that's the first thing, because we know that as soon as you pull back the lips, the shade just changes immediately. So, you know, I have a work through that I do with that. We don't tend to. We have done a couple of ELAB cases, but we mainly work now. Both of our eyes are so tuned together, and what we see, we kind of just work off a proper prescription. So, first thing is I'll do my shade assessment with something called, I think it's called a smile line. Have you seen that? So it's essentially a little handheld device that you can just basically put it has a polarizing filter on it. So you can put your shade tabs there. You can look at it with full on perfect daylight. And then you can put a filter on with a polar, and you're basically looking through a little lens. So I find with my shade assessment, that's really, really helpful. So I'll do that first. I'll do my, I'll basically map out exactly what shades I want to use. I'll use a few different shade guides for different parts of the tooth. And then I'll take my images. So I'll take bare flash images, I'll take polarized images, and then I will bare flash, polarized, and I'll take diffused images as well. So I'll take all three. And I'm also very conscious to take a picture of the wrong color, one either side, so that Ben has a really good indication of it, and so we can interpret it. Then we move on to, you're right, I'll take an impression over the top of the provisional, so he's got that information, and then I'll take out the provisional. It's obviously all screw retained. Everything's screw retained, nice and easy. So we'll take that out. I'll dip it, put an analog into a Dappens or into something that I can stand my analog in, put my crown in. I'll have marked on where the gingival level is. And then once that's set, I'll remove the crown, put my impression coping into the analog, and fill up with composite up to the, the emergence, the gingival level. Take it out in the mouth, and then we're good to go.
Perfect.
Yeah, so that's the only true way. That's the only true way to sort of replicate your crown. Otherwise, and if you've replicated it, because when you fit the permanent, if you've got a tiny bit of blanching, it's gone wrong. If it's a little bit too easy and things drop in, you've got it wrong. So that's the sort of thing, the detail you have to look at to learn from, and to make sure it doesn't happen.
Cool. Someone's just asking settings for bare flash. Are you using bare ring flash, bare twin flash?
Bare will be with, actually I have both on. To be fair, when I switch between, when I'm doing my shade shots, I'll do some with twin, and then I'll do some with just the ring flash, but my polarized is just with the ring flash. So it's one of those that historically, until I got twin flashes not that long ago, all of our shade pictures were, all of mine and Ben's shade prescriptions were with my bare flash, and with an old lens that had a hair in it. And since all the cases, I don't know where the hair came from, but basically because the cases were coming out so nicely, I wanted to send it off to get fixed, but Ben basically refused to let me take this hair out of this lens because so I still stick to that one, but you guys don't get to see that picture with the hair in it.
Yeah, we get the fancy twin flash diffusers ones,
yeah.
So these diagrams and things that you're doing,
yes,
you're doing those are going to be twin flash and contrasters and all that stuff. So what stage are you doing that? You're saying that you're looking at them with your snarl line, and you're looking at the shades there, and then you're retracting and going in finer once you've sort of got the main body shade. What's the thought process with those?
Yeah, so with those, I mean, I think I've got a good 3D eye for it. So, if somebody comes in and I look at the tooth, I'll know if it's 2M1. I'll know if it's a 3M1. Even more than, say, the Vita Classical, I can straight away look at it and know what it is. I think with doing it, the prescription comes at the end of the appointment, when I've basically zoomed in on teeth and taken individual polarized images of the other central. And when I've done that, it's obviously showing me absolutely everything. And then I'll draw it out. It will go with my prescription to Ben. But to be fair, the difficulty is that you may prescribe A2, you may prescribe A2 to your technician, but we all know that the build-up of, say, an implant crown, which is so thick, isn't built with A2. But to get to A2, you know, you're going to need these opacifiers in it. You're going to need your dentine. You're going to need your halos. You're going to need your translucency. So I think, you know, I think it's very difficult to suddenly doodle these pictures, send it to your technician, and think that immediately you're going to get these incredible results. Because actually, fundamentally, even if I didn't send this to Ben, he's good enough to see it within the tooth if our pictures are correct. I think number one, your pictures have to be correct. You have to have the right settings. You have to make sure the teeth are dry so that he can see it. But also, I think you've got to, you know, when it say comes to crown or bridge work, coming off from implants, I think where I help him is that I understand the depth that a restoration needs. So I'm not giving him minimal thickness. I'm still going conventional. I'm still giving him space to create, because you can't expect miracles on 0.3 of a mil. You just can't do it. So, you know, I think that is the key time to do it, when you're sending your pictures. And I think it's a good thing to do because it makes you analyze it. But I think, you know, from my respect, I mean, I know since I started doing it, you know, Ben's probably, he'd probably want to shoot me down for doing it, because now he gets so many like that. And, you know, get so many like that. But it's good that people are paying attention to it. That's excellent. You know, that people are striving to do better with it. But fundamentally, your own shade perception in the room has to be correct, because whatever you write there, he's following it. So my patients don't see him face to face. He works off my prescription. So, you know, I think that smile line device is great. I think that really helps. So I'd recommend that for others. And also just make sure that you do it immediately as soon as you start. I know I used to be conscious to get on with treatment. And it's quite hard to get in the routine of spending 15 minutes doing the shade. And then you're thinking, oh, crikey, I've still got loads of treatment to do. I've got patients to see. But, you know, just allocate your first 15 minutes of your appointment to nail your shade.
Yeah. And you said, obviously, that with the provisionals, you're not putting, obviously, anywhere near as much of this in. So with your provisional, are you just looking to get base shade right so you can at least evaluate that?
Oh, to be fair, we kind of go to town on our temps as well. We do, like, it shouldn't be possible with acrylic composite temps to do to the full extent, but you know, we manage it, and then chairside, sometimes if it comes back and there's too much fluorosis in it, I'll take it back. I'll add some composite on the front of it, you know, that we'll do it. Do it. And sometimes, you know, on the odd case, if we want to go to town, I'm going to show you this case where actually we made 2 single centrals for her just because we wanted to, just to see what we could do with it. And this goes into the shade prescription. So
perfect.
Where are we? So yeah, it's this one. So again, what I didn't say, important, just stump shade guides, really good. And then here's the prescription for this one. Okay, so there's loads going on there. You know, one of the things I find really useful with it is, yes, Ben can see the shades, but there might be certain things that I don't want mimicked. So at least you can put it on the picture. You can put it, and you've got your point of reference. Nobody can say, oh, you didn't tell me. So, you know, you both know exactly what you're going for. So here they are. So here's the 2 crowns. And one just has a tiny bit more tint and cervically than the other one. Shape-wise, they're pretty similar. And that was her final result. Now, to be fair, there was things at the outset that we knew were compromised on this, which I spoke to her about. So exactly the same. I flipped this tooth over and we put it here. And you could tell that we were going to get a black triangle if we mirrored the shape. So I discussed that with her at the outset. But she said she wanted a different shaped tooth, but she didn't want the black triangle. So you can see here that if we were to follow this line angle here, we would have matched the other tooth, but we would have ended up with a soft tissue discrepancy here. Okay. And the other thing, if you really critique this case, I think Ben and I were both, you know, with this case, if we wanted to improve, the texture on the final crown, the tooth is pretty smooth, and actually on one of the models just showed a bit of texture that Ben put into it. But the patient, you know, I told her, look, we can get this sorted. I can smooth it out. We don't have to seat it. But the patient just wouldn't let me not fit it. She loved it. Oh, sorry, we're going into my emails now.
I'll see the behind the scenes.
Yeah,
That's wonderful photos.
so no, this was actually this was the customized healing abutment that we were going to use on the central tomorrow. A bit of an idea. So here's a preparation for immediate implant. Implant in, temporary cylinder screwed into the implant, and then we make the customized healing abutment. And you know, when this case comes back 2 weeks later, so you can see no sutures, all done through the socket, and that's it at 2 weeks. And what you can see here, the papilla, you know, if I'd have let this site heal and gone in afterwards at 8 weeks, 10 weeks, this papilla would be lost, and this papilla would be lost. And yes, the final outcome would be fine, but the patient's more likely to get food trapping, more likely to get issues. So, you know, this is a much nicer way to deal with these cases.
Perfect. So we've got 10 minutes left.
And this you'll like. So quick run through another single central. This is now 7 years old, I think. And this is a case where you can see I've overgrown the soft tissue. Provisional in. So this is the old way I used to do it. This provisional got adapted about 3 or 4 times. Now, what you can tell from here is her central is wider than the other one. So we knew she must have had a midline diastema at some point, which the crown that failed didn't have that. So I only saw her with it fractured. So over a period of doing the soft tissue emergence, that's where we got to after playing around with it. And this is her at the 5-year recall, which you can see there. So loads of things are really important there. So, you know, you look at the emergence profile, we're trying to keep it really thin. We're trying to stay away from the bone peaks as much as we can, and then we're flaring it out. You know, and that's what's keeping that crestal bone there. The blueprint for the crown. So you can see exactly what we prescribe. And this one was quite bland. There wasn't too much to this. And there's the 5-year recall. She's actually in to see me, I think, end of this week. So I'll get a 7-year update.
Perfect. It's looking like it's quite fancy. Is this for some slides for something?
Oh yeah, so those are slides that we prepped before. So I don't know if anyone had seen, but Minesh and I had been in lockdown. We did a little webinar based upon you know, implant restorations for the GDPs and indirect ceramics. So, you know, that's something that we're both working on behind the scenes. And we're not too far away, sort of later on this year, looking to launch that course, fundamentally focusing on simple things, you know, simple facets of the stages of restoring implants, nothing surgical. So impression taking, creating provisionals, shade taking, customizing your temporaries, all things like that we feel that is so integral to day-to-day dentistry. And those people that don't do implants but want to get into restoring implants, we hope by the end of that course you would feel competent in doing that.
No, dude, that sounds awesome.
And hopefully share a couple of nice pictures as well.
Oh, that if it's both of you guys involved, I'm sure that goes without saying. So we've got I think about 6-7 minutes left. So if anyone's got any questions for Imi, please pop them into the chat or the Q&A, and I'll get them to him. If not, you can always obviously reach out, I'm sure, into the DMs later. But that was really, really good. I think you covered so much stuff there, and the cases, whereas literally everyone was saying the cases were beautiful. Salim's actually said mobile dental photography from Smileline. Is that what you mean? That's like the sort of 3-way.
Yeah, so I have a funny feeling what I'm using you can't get hold of anymore. And so there's only one in the country and I've got it now. There's that 3-way thing. It's basically an earlier version of that, just a little handheld device. I don't think that 3-way thing is the thing.
That's like the flash, isn't it?
Yeah, that's not ideal for this sort of thing. But you know, little things like making sure you're by the window, going to a well-lit room, all those sorts of things if you haven't got one of those devices. But yeah, they are actually. Let me see. I've probably got a image of one. Oh yeah, here we go. Here it is.
Uh-huh. So yeah, it's similar to that thing, isn't it? But yeah, this is a polarizing sort of
Yeah,
screen essentially.
yeah. So you can take the filter off it, and it will be non-polarized. But that's also really good for shade assessment.
Mm.
Basically, what it looks like.
And it doesn't exist anymore.
Yeah, I had someone ask me before, and I tried to look for it, and I couldn't find it on their website. So I think it has gone potentially.
We had a couple of good questions here. So first one in the Q&As was, or well, sort of paraphrase a bit, do we have enough control restoring implants we don't place? So do you do any of that? Do you do any restoring of stuff that you don't do? No.
No. So
End-to-end control, the Apple of implant
yeah,
placement.
yeah, end-to-end control. So, we have two specialist periodontists in the practice, and, I quite happily, I'm really happy for them to do implant cases, but, I would want them to do the whole case. So, as part of the planning, all the rest of it. So I'd rather they restore it, unless I'd have some involvement in the surgical phases.
Perfect. And Callum McCall has asked, what are the best OH advices that GDPs can give to patients with implants?
Yeah, great question.
Do you like water flossers? What sort
Yeah.
of stuff do you like to recommend?
Yeah, this is a really, really good question because, I give patients an idea of what I want them to do, especially for anterior implants at the end of treatment. And then they go to see the hygienist and something else is said to them. So with anterior implants, when I've worked so hard to get an interproximal papilla, and there is no blood supply in that area, etc., and someone's telling them to TP that zone, you're going to lose the papilla immediately. So best advice, posterior implants, TPs are fine. Anything anterior, don't even let them use it there. I think water flossers are good. Because at least they're using something. If they find it easy to use, at least it's cleansing the area. But if you imagine with an implant, you're trying to, if you've got a bone level implant, that junction where the crown meets the implant is very, it might be 3 millimeters, 3.5, 4 mils subgingival. So it's very difficult. That's the part that really needs cleaning. Mm-hmm. So the best thing to recommend, the only thing that's going to get down there is actually some tape. So you want to try and teach your patients to use some satin tape. You want them to, if they're using it conventionally, it's not going to get down there, but you want them to use a crossover technique where you essentially cross over the floss at the back on the palatal surface. And as you sort of work against the palatal surface, down the buccal side, it will just slip right under the cuff and it will get right down to the neck of the implant. So anything anterior, that's the best advice. And make sure they're doing it daily.
Perfect. We had a follow-up to the restoring implants you haven't placed, saying, meaning it from the perspective of someone who doesn't place implants at all. So, well, we've got a couple of minutes, literally. So just people who want to start in restoring, would you say, have a mentor who is prosthetically placing these implants and then that it's all in the right place and not have to play catch up with something that's plugged in some bone?
Absolutely. That's why I feel that restorative based, I think that's why I feel very lucky because of my restorative background and grounding. It makes my restorations very easy because I if there's no bone where I need it to be for a simple restoration, I place the bone where it needs to go and then I place the implant. So if you're starting up, you need to find a mentor that is very prosthetically driven, is aware of emergence, is aware of contact points, is aware of all of this. So it is so simple because if in however many 100 implants I've placed, I think I've only ever had to do one screw angle correction slightly. So and that I can't remember, and that was because I couldn't put the implant where it needed to be because it was going to be in the mental nerve. So that one just needed a slight angulation correction on it. So I think that's really important that you find the right mentor that's on board with that.
Pros first, absolutely.
Pros
I think we're literally at 59 minutes, so we're going to have to jump before it kicks us off. I mean, this has been awesome. I think we're going to have to get you on again by the looks of it. Maybe after the summer, just before that course comes out.
Yeah. Thanks for having me. Had a really, great fun. Hopefully people enjoyed it.
Cheers. Cheers, everyone.
Okay. Cheers, mate.